Every baby deserves a healthy start in life. The first 28 days of life, the neonatal period, is critical for the survival of the child. In Nigeria, about 1/4 of the estimated 1 million children who die before the age of 5 years do so in this neonatal period. Every day in Nigeria, about 700 babies die, the highest number of newborn deaths in Africa and the third highest globally. With a population of over 4 million people in 14 local government areas, Zamfara State, like many of the other states in Nigeria's northwest zone, has significant challenges with health delivery and environmental sustainability. The 2013 National Demographic and Health Survey showed Zamfara State as having one of the lowest antenatal care by skilled provider at 22.4% compared to a national average of 60.6% and delivery by skilled provider at 6.1%. Home delivery accounts for over 90% with traditional birth attendants playing more role than other birth attendants in the state. Similarly, maternal mortality and neonatal mortality remain unacceptably high within the Northwest Zone. In March 2007, the Federal Ministry of Health adopted the National Integrated Maternal, Newborn and Child Health Strategy. This strategy primarily aims at reducing maternal, newborn and child morbidity and mortality in line with the MDGs 4 and 5. The National Integrated Maternal, Newborn and Child Health Strategy organizes the interventions by 3 service delivery modes, including community-based service. However, in spite of a number of currently running funding supports to improve maternal and neonatal health in the state, access to maternal and neonatal care is still within limited reach. Against this backdrop, the Bill and Melinda Gates Foundation, in partnership with the Nigeria Governors Forum, initiated the Nigeria Governors Leadership Challenge Grant Management. To fast-track the execution of the award grant, the Society for Family Health was commissioned as the grant administrator for all winning states by the Gates Foundation. In the Leadership Challenge, Zamfara State emerged as the highest performer on polio eradication and routine immunization implementer in 2012. This placement awarded to Zamfara State came with a price of 79,400,000 naira grant and a 40,375,000 naira matching grant fund to total 160,500,000 naira when the state government contributed its equivalent grant fund of 40,375,000. This award was to promote access to quality maternal and neonatal health care and safe drinking water in selected communities. To improve hospital delivery and postnatal services, the project was conceived to fill existing gaps in basic equipment, staff capacity, community-level awareness, and referrals in rural communities in order to contribute to the reduction in maternal and neonatal mortality in Zamfara State.
As you know, Zamfara State, like other northwestern states, we have a high rate of maternal mortality. In fact, almost double the national average. And that's why we decided to build these maternal and child health centers in 14 local governments. The criteria is that we are supposed to choose hard to reach areas. That's the criteria we use. Of course, we came to choosing these locations in consultation with the local government chairman. And as you can see for yourself, most of the places we visited with you are hard to reach. So after a year, we are going to evaluate and see how successful they are. And the state government is really ready to replicate in other areas.
To maintain an effective continuum of project management from planning to implementation, the NGLCGM project in Zamfara State was managed by a 7-member state implementation team with defined technical, financial and administrative responsibilities made up of a state focal person, state embedded technical consultant, the directors of primary health care at the Ministry of Health and Ministry of Local Government and Chieftaincy Affairs, executive secretary of the Primary Health Care Board, the representatives of the Traditional Council of Chiefs, and the territorial manager of SFH. The Memorandum of Understanding was signed in January 2014 to foster a relationship of cooperation and mutual support between the stakeholders as they work together to promote the social, economic, and health development of Zamfara State and Nigeria in general. The collaboration was to improve on the healthcare needs of selected communities by upgrading obstetrics centers, primary health centers, training of health providers, including traditional birth attendants.
I provide both technical, logistic, and administrative support to the project. At the community level, the health facilities that we built for rural communities, we also had community mobilization activities where we engaged two civil society organizations that work through TBAs to mobilize communities. From the beginning of the project, we're interested in sustaining the project. Sustainability was a key component of the project, even beyond the MDGs, which the project focuses. And that is why we have carefully planned it to ensure that the key stakeholders who are at the community level participate actively in the project. For instance, the traditional birth attendants were used to mobilize women, pregnant women, to the health facilities, and women also who are in labor.
Immediately after the MOU was signed, activities to achieve the project objectives began intensely. Following the customary procedure in project implementation of this kind, the SFH Territorial Manager, Sokoto Zone, mobilized his team to various sites and work commenced. The sites assessed and selected for implementation of the NGLCGM project in Zamfara State included Magami in Kauranamuda local government area, Gwaram in Talata Mafara local government area, Dako in Bakura local government area, Kogo in Maradun local government area, Damanfemi in Birnin Magaji local government area, Kwaran Ganuwa in Safe local government area, Gobinrawa in Anka local government area, Shemori in Gusau local government area, Yambuki in Zumi local government area, Kuria in Shinkafi local government area, Akawo in Bukuyum local government area, Falanbirni in Gumi local government area, Gobirawan Chali in Maru local government area, and Babangebe in Bugundu local government area. As scheduled in the work plan, the team facilitated the construction of a health facility in each of the identified 14 communities. To supervise the construction process and guarantee quality and timelessness of the project according to SFH procurement procedures, the services of an architect to design a building plan for construction in communities without existing buildings and a consulting building engineer were engaged. Each health facility provided space for general consulting, observation for the maternity, labor, general ward, pharmacy, store, and toilets. The cost for each location was based on the level of construction work required. As construction work progressed, procurement of equipment and drugs also commenced. The procurement was contracted to professionals with experience and track record of quality delivery. Items to be procured for use at each of the 14 selected health facilities included hospital ward beds, delivery equipment, and drugs. Upgrading the health facilities included the provision of safe drinking water to communities. As a result, one borehole each was drilled in 10 of the 14 selected communities. The boreholes served both the health facilities and the host communities. While the people rejoiced with the progress of work as their health centers were being upgraded, the team set out to build the human capacity for clinical care and community mobilization. The human capacity development required the review of training curriculum. Trainings were conducted for health workers to facilitate clinical obstetric care and traditional birth attendants, TBAs, to facilitate community mobilization of pregnant women. A team of 5 experts sourced locally were engaged to review and update the training curriculum for both life-saving skills for health workers and interpersonal communications for TBAs. As the training curriculum were being reviewed, state-level training of 20 facilitators comprising of the 14 LGA reproductive health coordinators or their designate and 3 program officers were undertaken to provide a pool of facilitators for the step-down training. To accelerate progress in reducing maternal and child mortality, training on basic essential obstetric care were facilitated. The training on life-saving skills involved 38 health workers selected from referral facilities in and around intervention communities. The biggest impact for the human capacity development was the training on community mobilization and referral. 112 traditional birth attendants, 8 per local government area, residents in and around the community of intervention were trained and equipped to mobilize women for antenatal care and hospital delivery. The training also developed their capacity to support the pregnant women in identifying danger signs in pregnancy, prepare them for delivery, and conduct delivery when necessary or refer cases of complication to health facilities for care. The training was conducted at 4 zonal locations and monitored by the State Implementation Team SIT members for quality control.
Actually, when we were still there, we had a lot of challenges because even the structure was not even encouraging the women coming to the hospital. But due to the effort that they impacted here, at least there's a great turn-up with building a structure like this where we conduct delivery and other activities in the hospital. I want to say a big thank you to them.
Understanding what is needed to consolidate and scale up cost-effective maternal and child health interventions, the implementation team mobilized the communities for service uptake to the health facilities. The trained traditional birth attendants were deployed in their respective communities and supported to conduct interpersonal communication using customized information charts. The TBAs educated women of reproductive age, particularly the pregnant ones, to recognize danger signs in pregnancy and on the need to receive antenatal care and deliver at the health facilities. From then on, the TBAs went to work referring the women to the clinic for the services as soon as the facilities were upgraded and open. As part of the behavior change campaign, some communities within the catchment areas of the upgraded health facilities were mobilized. Advocacy meetings were held with both the traditional and religious leaders in 2 key communities to enlist their support for the project. Similarly, town hall meetings were conducted with key stakeholders in the communities at the start of the project, as well as the closeout phase of the project. To generate goodwill and facilitate community ownership and participation, selected members of the project communities participated in each meeting to sensitize the stakeholders, get their input, and share progress report and challenges of the project. At the community facility level, an emergency transport system that will facilitate movement of women in labor from the community to the health center or from the health center to higher level facility was put in place. The project procured and equipped 1 tricycle ambulance for each of the 14 project communities to facilitate the new emergency system. Once this was done, a community-level program management system was developed to monitor implementation without additional support. To achieve this, A local non-governmental organization was engaged to coordinate the community mobilization and referral component, including training and periodic monitoring and evaluation with supervision by the state embedded technical consultant and territorial manager. 6 program officers were also engaged to facilitate implementation on the 14 selected communities. In each project community, the NGO coordinated monthly review meeting of TBAs and volunteers to allow for data collection, collation, and to discuss common project issues. Following the establishment of a community-level program management system, an integrated supportive supervision and other monitoring and evaluation processes were set up. The system tracked the project progress and used the acquired data to improve programs. Key to this integrated system are the program officers and SIT members who monitor implementation using validated checklists for quality assurance. Scheduled review meetings with the volunteers, LGA health educators, program officers and SIT members were conducted to review progress and challenges and discuss way forward for the project.
Due to the health indices we are getting from our rural mothers, we plan to build a maternity unit in each local government and hard reach where the grassroots communities are. We really appreciate the effort of Bill and Melinda Gates in pushing us and giving us a support to utilize and build this maternity unit in each local government of Zamfara State. And now with effort of state government contribute their own counterfund funding, and we sat down and arranged to build those clinics for the interest of our community people in the local government at grassroots.
We sat down with the committee assigned by His Excellency. So we decided and prioritized on our problem. Our main challenges in the State is higher maternal death, which we are facing. I know that we have some partners that are coming to support us, but we decided to construct one maternal clinic for LGA, which I could remember for the first 4 months. I can say we came here in this place. We discovered the community here. So we discovered that the community is densely populated with high number of settlement and catchment areas here. So we promised them that we are going to construct a maternal clinic here, which they welcome with our proposal.
To sustain the project, several pledges were made by the stakeholders at both community and health system levels. The community leaders are unanimous in their commitment to take custody of the tricycle ambulance, facilitate through the village head committee the maintenance of the tricycle and borehole after close of project. The LGA chairman and Ministry of Local Government Affairs have pledged to staff the health facilities. Where possible, the LGA authorities will also be providing accommodation for the service provider to encourage staff retention.
The state government has even gone far. It has promised to construct staff houses for all the 14 health centers we have so far constructed. So I think the state government is really giving every cooperation that is needed.
Overall, the entire project underscores the importance of a community-driven health delivery strategy and support system as a basis for effective participation and ownership by the beneficiaries. Scoring big on health, the accelerated success of NGL-CGM in Zamfara State will require the sustained commitment at different levels of government, development agencies, non-governmental organizations, the private sector, and health professionals, as all babies deserve a healthy start in life. With maternal, newborn, and child health now at the forefront of the global development agenda, The walls of healthcare facilities has the potential to accelerate progress in reaching national and global sustainable development goals in health.